So, very good interaction. Next topic is colonoscopic appendectomy. Is it possible? Dr. Prashant Rahate.
Yeah, thank you. And in continuation with the thoughts provoked by Dr. GV, same thing here, colonoscopic appendectomy.
PPT या video?
PPT. इधर नहीं आया. Yeah. So colonoscopic appendectomy, is it possible? So no disclosures except thanks to organizers and special thanks to Dr. Ramesh Arnari. Unfortunately, he is not here. He saw my video and asked the organizers to include this. Thank you very much, organizers. I was searching and thinking since last almost 10 years, and various devised where the instruments were devised and institutional ethics committee approval was taken. The willingness of the patient and informed consent was taken. CO2 insufflation in colonoscopy was done, and readiness for laparoscopy if needed. For that matter, we are already doing flexible endoscopic transvaginal appendectomy, transvaginal cholecystectomy, and transgastric cholecystectomy also. So this 72-year-old gentleman diagnosed as appendicitis, CT abdomen proved the diagnosis, and request of conservative management was there from the patient side and the relative side. Considering the age, I requested him to undergo colonoscopy to rule out secondary appendicitis, whether there is any osteal tumor or like that. So the ostium was wide and inflamed, was suggested to undergo colonoscopic appendicectomy, and if failed, then laparoscopic appendicectomy. So the instrument needed are very simple: the biliary balloon, 12 mm by 13.5 by 15, and right tooth forceps and an endoscope, endoloop. Bowel preparation is not needed. Irrigation machine might be needed. This is the video. So we reached the cecum. Patient had a right-sided diverticuli also, so that biliary balloon entered into the ostium, and it dilated, and if there is debris, we can flush that. So we dilated it for complete 1 minute. We released it and then again dilated, so that to confirm that there is no bleeding, extra dilatation is not there. There is no breach in the mucosa. So that balloon dilatation was done for almost a minute, so that proper stretching of the muscles are there, so that I can invert completely the appendix along with the mesoappendix. That is important. If mesoappendix is thickened as the BMI if more, if the patient's BMI is more, this procedure is to be avoided. So then rat tooth forceps, we little bit of modified that rat tooth forceps. We applied vacuum to the plastic sheet so that it can catch hold of the tip properly, and the appendicular lumen can collapse it. We have patentized this particular forceps. So catching hold of that, we need at least 6 to 9 times this catching hold of the tip. And when we started pulling it, we need to, sometimes the pull was coming till the hepatic flexure. So it was great force it was needed, and that vacuum prevented slippage of that. I think the pus came out. And now you can see that I am pulling it, and the pull is coming up to the hepatic flexure. Yeah, that has come up to the hepatic flexure, and then that appendix is completely everted. So proper flushing is done. Now the difficult thing is how to loop that base of the appendix. Might be the double lumen endoscope might be very handy here. But here, along with the proper suctioning, the loop juggled down to the base of the appendix, and then it was applied. You can see the ileocecal junction there. So it was really difficult. It took almost 10-15 minutes, multiple attempts, then that was applied. This can even be cut by the endocut, the appendix, for the histopathology. So that is how the difficulties faced were the failure to evert the appendix. We attempted this particular procedure in 32 cases since 2018, and COVID period was little bit of dormant. Could complete the procedure in 5 cases only, and applying loop at the base is very tricky and difficult. Which patient should be attempted? The younger, short history of appendicitis, early appendicitis, they are better. Non-recurrent with lesser BMI. So these are our 5 patients. The duration of the illness was 1 to 3 days. The TLC count was not much. BMI was around less than 30 in all patients. Operative time was ranging from 38 minutes to 72 minutes. The attempts to evert that were almost 6 to 9. Pus was there. There was fecolit in only 1 case, and loop application took almost 20 to 22 minutes. Ultrasound findings, the diameter of the appendix was around 6 to 8 millimeter. Failed patient, most of the patients were having more than 30 BMI. There were 7 patients with less than 30 BMI. Duration of the symptoms was more than 3 days in 20 patients and less than 3 days in 8 patients. Anesthesia needed was only sedation. Hospitalization, they were ready for discharge in 4 hours. As per the VAS score of pain, you can see the single port, the 3 port, the pain is comparatively very high, and that is a small red line down. The VAS score was less than 1 in all 5 patients. There are reports available in the literature, but all the patients, they had inverted appendix. I don't know what is this inverted appendix. Pediatric surgeon might be helping in me about that inversion appendix. That is the procedure which was done by pediatric surgeon way back. And all these inverted appendix had inflamed appendix, and they were removed as polyps. So colonoscopic appendectomy, this is again a literature, but again there was mention that it was the inverted appendix. There are some reports in literature where design and instrumentation of new device, they have devised this type of instrumentations. Some have gone in with modification. The snare and the biopsy forceps was entering like this, and they did appendectomy, but this was again an inverted appendix. So these are the various things available. This is a fantastic case which is available in this literature by Tauche et al., where they did virtual colonoscopy, delineated the appendix. There was a lesion at the ostium, a flat lesion at the ostium. So they did a full thickness resection. So full thickness resection was done, and then peritoneum was entered, and the mesoappendix was tackled, and the rent was closed down by the clips, and a common loop was applied over all the loops. So that is the literature available. These are the various types of eversion of the appendix. This is the everted appendix, how it looks like. Endoscopic retrograde appendicitis treatment, ERAT, that can be done in cases, particularly this case, can be helpful in mucocele of the appendix. It will drain complete mucous material, and it will decrease the morbidity and chances of pseudomyxoma peritonei. And also colonoscopy can tell us about the cause of mucosal development, and then we can go ahead with laparoscopic resection. This is the US patent, which is for our the instrument. In conclusion, the endoscopic appendectomy and cholecystectomy is also feasible, needs more standardization. Endoscopic cholecystectomy, transgastric, transvaginal is also possible. The only difficulty is that we get the inverted image. So what we did, we overturned the monitor itself so that we are getting a proper image, not inverted image. So thank you very much. These are short videos of transgastric and transvaginal. So that was our, so colonoscopy definitely has some place in appendicitis. And this is to be standardized, proper instrumentation is to be devised, proper protocols are to be made, some legal stature is to be given to that. So definitely there is some place to the colonoscopy in appendicitis. Thank you very much.
Thank you. Very
So
innovative talk.
Yes.
I request Dr. Goenka
please
and Dr.
continue that
Jivirai
video.
to please give your comments.
Please continue that video.
Okay, please. Okay.
Comes, who is a master in some of the technology which we talked about. I remember 18 years back, he did the first transgastric appendectomy. And I remember the standing ovation which he got in one of the meetings. I have a couple of questions for you. One is that what is early appendicitis? You said that one of the indications is early appendicitis. We also know now with the recent literature that some of these early appendicitis do not require any surgery. So you can manage possibly them with conservative medical treatment. So how do we decide whether the patient requires?
See, this is a very tricky question. I agree with you that early appendicitis, they don't need surgery. But at the age of 72 years, if there is a documented evidence that a particular patient is having appendicitis with all that atherosclerosis and things, that patient is going to have some complication. So we should advise them and not to advise conservative management.
So second point is that 5 out of 32 you said you were successful. So is there any predictors beforehand by some imaging that you will know that which patients you should try? Because if you tell the relative or patient that I'm going to do a colonoscopic appendectomy and then you come back and say, no, it could not be done, they would think that it's a failure of the procedure. So is there any way you can predict beforehand?
No, it is very difficult. It is too early to say that. But definitely we are going to convince them that if I don't do it colonoscopically, I am going to do it laparoscopically.
So do you foresee that I'll be doing it in the near future?
No. In early cases, we tried in 32 cases.
No, I said, can this be a procedure done by the medical gastroenterologist?
Sure. Yeah, comments
just
from
actually,
you.
again, medical gastroenterologist, surgical gastroenterologist is not the question. It's the endoscopists who should be doing it. Second thing, I think we should all understand that these are evolving procedures. See, like when POEM started, actually, nobody believed that it can be done. But again, I think one of the reasons actually POEM became very popular basically because of the esophageal manometry that came in a big way. Early lesions were started being picked up and you started getting good results with that. We never had this manometry studies when laparoscopic LS was the initial part. The success of POEM basically is related to the manometry studies that you have as of today, wherein early lesions are being picked up and you're able to show good results in this patient. Likewise, these technologies are evolving. Actually, I'm not saying that these will be the thing, but we'll have a subset of patients whom it can be done. Not every patient is, it can be done actually. So obviously there will be a gray zone between the endoscopy and laparoscopy, but I'm sure these will resolve over the period of time.
Thanks a lot. Congratulations, Dr. Rahate, for giving us newer concepts.